Go.
Hello there. My name is Dr. Asan Hussain. I'm an assistant professor at the Department of Ophthalmology and Visual Sciences in Halifax, Nova Scotia. Thank you for joining today. Today I'll be talking to you about lower eyelid entropion. So I will be reserving upper eyelid entropion as a separate case and discussion because that is somewhat of a different presentation and management. So what is a lower eyelid entropion? Well, by definition, this is a rotation of the eyelid margin toward the globe. And I myself use the meibomian gland orifice's position as a guide as to whether a patient has a lid entropion or ectropion, because it can be very subtle and in its very early stages. And what happens in these patients is because of the rolling in of the eyelid, the keratinized skin and eyelashes start to rub against the inferior cornea and bulbar conjunctiva, and resulting in irritation. And usually these patients seek earlier help because of this irritation. So there are four main classifications of lower eyelid entropion. You will note that I have no financial disclosures, but CIBC is a mnemonic to use. First is congenital. This is a very rare form of lower lid entropion, much rarer than the more common epiblepharon, which can occur in children. But the difference is, compared to epiblepharon, that in congenital entropion, the tarsal plate is inverted. And this malposition does not usually resolve spontaneously and requires surgical intervention early on to prevent corneal morbidity. The cause has been postulated to be abnormal insertion of the lower eyelid retractors. By far the commonest cause, of course, is involutional entropion. And therefore, this is by definition seen in older patients. And there are four main presumed causes of this anatomically, although one of these, the last one, is been debated not to be a predominant cause. The first is laxity, dehiscence, or disinsertion of the lower eyelid retractors, and I'll show you a picture of that in a moment. The second is overriding of the preseptal orbicularis oculi muscle over the pretarsal OO muscle. The third is horizontal eyelid laxity, and the fourth is enophthalmos. But enophthalmos, like I said, has not been shown to be a significant factor in the etiology of this problem. By far, it is the eyelid retractor problem that needs to be corrected. Other causes, cicatricial causes, such as from conditions such as chemical burns, surgery, from accidental trauma, topical glaucoma medications, mucous membrane pemphigoid, trachoma, Stevens-Johnson syndrome. It can also be seen through extruding orbital implants. And finally, spastic or blepharospastic entropion. That can occur with in patients who have blepharospasm, and usually an underlying ocular cause of irritation, like dry eye, causing them to be squeezing their eye, and over time, through rubbing or through the irritation, the eyelid starts to turn in intermittently. And I should mention, before I forget, during this case, that you may sometimes see a patient who's been referred for a lower lid entropion, and they come to your office and you don't see anything. And in fact, their eyelid looks completely normal. And what they may in fact have is this spastic entropion. And there's a paper by a colleague of mine from the UK, Paul Badley, in OPRS, where you do a test of induction. So you have to see if you can induce the entropion. And the way I do it usually is I ask the patient to close forcefully against a retracted upper eyelid, which I do for them. I retract the upper lid and they have to forcefully close their eyelid. And that spastic component is usually induced, and you can see the lid turn in. Another way of doing it is to put in tetracaine. Alkane doesn't irritate the eye as much as tetracaine. So tetracaine, unfortunately, with the irritation, will then result in the lid malposition becoming more evident. So anatomically, you should know your lower lid anatomy. This is a perfect case to revise your lower lid anatomy. I won't go through this completely because, of course, this is a whole topic in itself. But be aware of the three lamellae. The anterior is the lamellae is the skin and orbicularis muscle. The middle lamella is the orbital septum. The inferior eyelid retractors and the orbital fat. And the posterior lamella is the tarsal plate and conjunctiva. And what happens in lower lid entropion with involutional entropion is that the lower lid retractors become lax or dehisce, and this results in a rotation of the lid margin inward toward the globe. And also you can get overriding of the pre-septal orbicularis oculi over the pre-tarsal. These pictures are taken from Brian Leatherbauer's excellent text in oculoplastic surgery, called Oculoplastic Surgery. And in your exams, it is quite common for you to be asked that if an incision was made on the eyelid at a specific point, what structures would you pass through? So be sure that you know the answer to that. Let's say you went 4 or 5 millimeters below the tarsus in the lower lid. You would go through skin, orbicularis oculi muscle, the orbital septum, the pre-aponeurotic fat, the lower eyelid retractors, and conjunctiva. So be aware of your anatomy. So when you're dealing with a patient with lower lid entropion, they, of course, will present with a history of irritation, photophobia, maybe a red eye, maybe a discharge. They may present with a history, of course, of surgery. And it's important to know whether they've had previous attempts at lower lid repair, because that will also possibly determine what you're going to do. Patients may say themselves that, they pull the lid down to give themselves some temporary relief, or even tape it themselves, which is a form of conservative management until they have surgery. Be aware of their drug history with any type of surgical patient. If they're on blood thinners, that will need to be, they'll need to be counseled on. What do you do in the examination? So the first thing to do is do a lid distraction test, where you pull the lid away from the eyelid and see if it snaps back and how quickly it does so. That gives you an indication of how stable the lid is. Pull the lid away from the globe and see again how lax it is. If it's loose, that gives you an indication of horizontal laxity. Move the lid medially and laterally to give you an indication of if the lateral canthal tendon or medial canthal tendons are lax as well. Have a look at in the fornix. I have a picture on my Instagram account of showing you how in a patient you can actually see sometimes the dehiscence of the lower lid retractors. There's a white line which can give you an indication that that's occurred. You then want to do a careful slit lamp examination. Look for scarring, look at the inferior fornix particularly, look for keratin over the lid margin, look for any cicatricial changes. So again, just to repeat, you're doing a lid distraction, a lid snapback, and a horizontal laxity test as well, which is called, they're called a snap test, a pinch test, and a distraction test. How do you manage these patients? Well, in terms of immediate management in your clinic, what I tend to do, and as I did with this patient, was to place immediate quicker sutures if the patient is happy to do so. It takes about under 10 minutes. I place 2 5-chromic double-ended sutures beginning within the fornix of the lower lid. So you're grabbing the retractors and then exiting on the skin just in the subciliary area with both ends and tying them there. And you're looking for correction of the lid, but not overcorrection. And by that I mean you're not getting a punctal entropion. And the patients are very happy, they've got relief of it, and they can wait until their surgery. If you can't do that, you may want to consider a bandage contact lens. Some patients do well with a botulinum toxin injection to the lower lid orbicularis oculi. That can relieve a spastic entropion. But the easiest thing is to say to the patient, you can put a bit of tape on to pull the lid away from their eye until they wait for the surgery. And what kind of surgery do we do? Well, there are apparently over 100 procedures described for the repair of lower eyelid entropion. So, you're very welcome to go through those. But I would say to you that one size does not fit all in lower lid malposition surgery. In fact, this is probably one of the highest reasons why, one of the commonest reasons why I get referred patients who have had failed surgery, because the initial operation was just not appropriate. So usually the quicker sutures are a good thing to do, but if the retractors have dehisced, you will have to combine retractor advancement with a lateral tarsal strip if there is also horizontal laxity. Some people actually do a formal wedge resection of the eyelid if there is significant laxity of the lower lid. These procedures are usually done under local anesthesia. But very important, of course, like I mentioned, to know about blood thinners and to deal with that accordingly. Post-operatively, I give my patients a list of instructions on what to do and how to care for their surgery, and most do very well, very well. There are great cases for surgeons, for residents attached to oculoplastics to learn their basic surgical skills. Okay, that's the end of that case. Thank you.
Excellent.